Good afternoon and welcome everybody to this joint webinar with ESE Indo-Iran and HISPI. The title of this very interesting webinar is Recent Therapeutic Perspective for Rare Endocrine Disease. And my name is Elena Valassi. I am the co-chair of the Rare Disease Committee of the European Society of Endocrinology. And my co-chair is Dr. Mario De Thomas. Mario?
Thank you, Elena. As Elena said, my name is Mario Thomas. I'm working as a clinician scientist at the University Hospital of Würzburg in Germany. And it's a pleasure for me to be here and co-chair with you this amazing session.
Good. So before starting, we would like to remember that, of course, this webinar is recorded, so it will be available on the ESE website in the next couple of weeks. And very important, you can ask questions. You can write your questions in the corresponding space for Q&A, which is in the bottom of your screen. So I think that now we can start with the first speaker. So the first speaker is Professor Mohamad Maghnie from Italy. And the title of his presentation is Long-Acting Recombinant Human Growth Hormone. Is it an improvement over daily recombinant human GH? But before, a brief introduction on him. Professor Maghnie is a professor of pediatrics and a PhD in pediatric endocrinology. He is the head of the Pediatric Clinic, Clinical Service in Pediatric Endocrinology, Diabetes and Metabolism of the Giannina Gaslini Institute in Genoa, and director of the Department of Neuroscience, Rehabilitation, Ophthalmology, Genetics, Maternal and Child Health. He is also currently the director of the Pediatric Residency Program at the University of Genoa and the supervisor of several postgraduate research students and postdoctoral fellows working in his research group. Professor Maghnie received National International Award of Excellence in Pediatric Endocrinology and he has authored over 300 original articles, textbook chapter, and scholarly reviews in a number of high-impact journals, and actually on his major research interests, which include growth disorder and the treatment and the management of pediatric pituitary disorders. So, Professor Maghnie, you can start whenever you want, and thanks for accepting our invitation.
Thank you very much. Good afternoon, everyone. Thank you, Elena. Thank you, Mario, for inviting me and for your words. So my task today is to speak on long-acting growth hormone. Is it an improvement over daily? These are my disclosures. So what I would like to share with you over the next 20 minutes is something about what is the burden and indication of daily versus long-acting, and what is the efficacy of long-acting as compared to daily, and then go to the safety and give you some summary. So we all know from the pediatric perspective that daily injections have a lot of burdens that include the children's experience with injection site pain among approximately 54 to 80% of the children. Was they dislike it, they have fear, there is limitations for their daily activities, and they're, of course, unhappy about the injection schedule. At the same, from the caregiver's perspective, because they complain about the time that need to prepare the injections, the need to stop and interrupt activities, the family travel around 50% of them, the worry about administering treatment and causing pain to the child, and of course, frustration. And according to the different items of the life interference questionnaire reported in the literatures, spending the night away from home and travel represent a burden. So the summary of the burden, the pediatric growth hormone deficiency process, we know that is multifaceted because it impacts the physical activities and the quality of life. And this from the patient perspective, for the caregiver is a highly distressed experience. And of course, for the physicians as well, there is a burden of managing parental expectations, desire, and entitlement to treatment. So treatment burden indeed is a key driver of adherence. As you can see from this paper reported in 2011, that this is non-adherence with growth hormone treatment is common. And this will lead to high velocity SDS over a short time of 6-8 months, showing that the high velocity has been reported in those who missed less than one injection per week, and it's a medium high velocity SDS, significantly compared to the adherence, and it is low for those who missed more than 3 doses per week. And what is the impact of this in terms of longer term? In terms of the first study that has been reported, while in this ESE Connect observational study, it showed that poor adherence result in suboptimal growth after 2 years. And here you can see that suboptimal adherence resulted in the loss of 0.34 SD in terms of height. And here you can see, here it's evident between the 25th percentile as compared to the 50th percentile and 75th percentile as compared to 25th percentile. So we know that the daily injection may lead over time even to worsening of the final outcomes. So now why consider long-acting preparations? And here you can see from this discrete choice experiment approach among adults and adolescent and caregivers, here you can see that injection schedule was represent the highest burden, more than 50%, and in the light blue in the adolescent is 44% in the adult, and the pediatric 44%. So injection schedule was indeed the strongest predictor of choice for the total sample of each patient group. Of course, I mean, choosing between 52 versus 365 injections with similar efficacy, safety is the design. And here you can see the percentage of participants that would choose the schedule different. That's suggesting that long-acting is one of the most preferred injection schedule. And of course, this is more than 80% in the adolescent, is approximately 8% in the pediatric and parents, and it is 75% in overall adults, 64 in the adult patients. So this is another paper reported in 2025 showing that approximately 80% of children between 3 to 11 and 84% of adolescents between 12 and 18 years would choose once weekly profile over the current treatment. So what is the indication? What are this would be the impact of long acting? So the desire to have long acting is to decrease injection frequency, increase flexibility, and that's offered for the patients and family alternatives, the potential to improve adherence, and of course, the potential to maximize efficacy. That's through the better adherence. So does long-acting activate the growth hormone receptors as compared to daily growth hormone? This is somapacitan binding characterization. Here you can see this has the study design in growth hormone deficient hypovasectomized rat, and it showed that somapacitan binds to the growth hormone receptor in the presence and absence of albumin. It is distributed in the hypertrophic zone and primary spongiosa in the epiphysis of the proximal tibia. And of course, somapacitan activate the growth hormone receptor and STAT5B, leading to IGF-1 induction and long-acting. So this is a proof that long-acting acts at the growth hormone receptor, leading to IGF-1 generation. So what we do know about the efficacy of daily as compared to long-acting. Here you can see that daily recombinant growth hormone has been in clinical use since 1985, was the first approval for pediatric recombinant for pediatric growth hormone deficiency, and this was after the Creutzfeldt-Jakob disease reported in the literature due to the use of human recombinant growth hormone. And indeed, over time, we had approval in different indications that include chronic renal insufficiency, in adult growth hormone 96, Prader-Willi, Turner syndrome, small for gestational age, idiopathic short stature, SHOX deficiency, and Noonan syndrome. So indeed, what do we know about long-acting growth hormone preparation? So here you can see there are 6 products, 2 from China, 1 from South Korea, and 3 have been approved in Europe and United States. So long-acting indeed was designed to release growth hormone slowly over time, reducing the need for frequent, and this include, of course, through different molecule, that's pegylation, in blue, as you can see, for Gintrolone, for Pegpizan, for Skytrofa, and for sustained release depot in eutropin, and for growth hormone fusing protein for somatrogon, and albumin-binding growth hormone for Sogroya or Somapacita. What about the indications? This has been approved in the pediatric age, as you can see, for children with growth hormone deficiency. We don't have other indications. For over than 3 years for Somatrogon, over than 1 year or more than 11.5 kilogram for Lonapexomatropine, and this has been approved, of course, by EMA and by EMA and FDA for Somapacitan for more than 2.5 or 3 years. Indeed, 2 products have been approved for the adults, one recent one in August in 2020 for the Somapacitan, and recently in July 2025 for Lonapexomatropine. So the recommendation, as I told you, is for GHD, for growth hormone deficiency. So what about patients not included in the published clinical trial for long-acting? So very young children between 1 to 3 years, those with severe growth hormone deficiency may be at risk for increased hypoglycemia. This is due to pharmacokinetic of IGF-1. I'll come back to this in a minute. And of course, the childhood cancer survivor with GHD, there is some special consideration should be given to dosing and IGF-1 monitoring. And we know that long-acting can be initiated from the last recommendation we published in JCM 2025, 6 months or after last treatment for childhood craniopharyngioma without increased risk for a new event. So the same for Prader-Willi syndrome and pediatric non-GHD. There are ongoing trials for SGI, Turner syndrome, SHOX deficiency. So we'll know more. We'll have more about this in the future. So, in brief, which patients are most likely to benefit from long-acting? Children at increased risk of poor adherence to daily GH, such as teenagers, and those with previously documented poor adherence. Children taking multiple medication. Children with neurodiversity or neurological behavior disorders. Children with parent and caregiver who experience anxiety. Children with more than one home and frequent travel, and children whose family or socioeconomical disadvantage from and for whom growth hormone treatment is an additional burden. So the question is there evidence of clinically relevant differences in treatment between daily versus long-acting? Are growth and growth velocity comparable between daily and long-acting treatment? And are there differences in changes in body composition between daily growth hormone or metabolic effect and long-acting? And of course, is there evidence for better adherence? Is there real-life clinical experience concerning efficacy and adherence? And how does long-acting compare to daily growth hormone in terms of its effect on quality of life? And here you can see this paper we have reported in JCM in the December 2022. This is the full cohort KIGS analysis in approximately 83,000 children that include 50% of idiopathic GHD, 10% of congenital GHD, craniopharyngioma, and other conditions that include Prader-Willi and other syndrome. And here you can see that the best efficacy was shown in those with congenital GHD as well as in idiopathic compared to other conditions as well, leading to approximately 2 standard deviation score improvement and height gain over time for idiopathic GHD as compared to the other conditions. So what happened for long-acting? And here you can see the phase 3 data showing that somapacitan, lonapexomatropine, and somatrogon was different. There is no dose equivalence because it's 0.16 milligram per kilo per week for somapacitan compared to 0.24 for lonapexomatropine and 0.66 milligram per week for somatrogon. Here you can see same characteristics between patients, which are the mean age 6.4 as compared to 8.5 and 7.8. And so we have only patients pre-pubertal with similar height deficit and similar IGF-1 SDS, approximately less than 2 minus 2 standard deviation. And here you can see the annualized height velocity comparison for somapacitan, lonapexomatropine, and somatrogon, showing non-inferiority as to height velocity compared to daily. So 11.2 versus 11.7, 11.2 versus 10.3, and 10.1 versus 9.8. What about those switching patients? Those were naive patients. Here you can see that mean height velocity over 2 years for those with the extension study moving from somatropine to long-acting, showing the same mean centimeter per year. And here you can see the mean height SDS for those with the extended study for 2-year data for somatrogon. And here you can see the somatropine versus somatrogon, showing that even those who switch from daily to somatrogon have similar results. So what about the IGF-1 SDS? Here you can see that the mean IGF-1 SDS in the somapacitan group, the long-acting versus daily, and here you can see the lonapexomatropine, the long-acting versus daily, and here you can see the somatrogon, showing that IGF-1, mean IGF-1 SDS was higher than zero SDS in the 3 studies. What about the pharmacokinetic? Here you can see the differently from the daily, where we know that the IGF-1 profile is completely different. The IGF-1 peaked around the 2nd day after the long-acting injection, and the mean ranges, the mean IGF-1 level approximately similar to the daily is around 4 to 4.5 day. And here you can see that the IGF-1 is completely different. What does that mean in terms of clinical practice? That meaning that we need to have the sample around the 4th day, and we don't know exactly about the safety issue about these peaks of IGF-1. And of course, simulation may aid clinician in interpreting IGF-1 level, because in terms of the organization process, it's not always easy to get the patient sampling at the 4 or 5 days. So the predicted differences between IGF-1 SDS and the average of IGF-1 was 90%, of course, confidence interval. So what about the impact of weekly somatrogon as compared to the burden observed in daily? And here you can see the proportion of patients and caregivers who selected weekly schedule, showing that long-acting is really much more favorable in choice of the injection pen, of the pen use, and by patient life interference. And here you can see in terms of the caregiver interference is the same for the life interference, for the family life interference, and intention to comply of long-acting as compared to the daily. So in summary, long-acting and daily show comparable growth outcome. Long-acting may improve adherence through reduced injection, and there are still clinical gaps in understanding the long-term metabolic effects, adherence, and individualized response across different patient population beyond growth hormone deficiency. So last part of my talk about safety. So do long-acting preparations have similar safety, including benign intracranial hypertension, sleep capital tremor, epiphysis, incidence of cancer, or other adverse event? Do different long-acting preparation with different molecular weights have comparable adverse events? And do long-acting have similar impact on glucose metabolism, body composition, and fat, and bone health? So here what we know from daily, these are the data from the 50,000 children treated with growth hormone. And here you can see that any adverse event was approximately related in 3.2%. Severe adverse events was 0.7%. And here you can see that severe adverse events were by patient characteristic, showing that the highest adverse event were showing neoplasm, and this mainly in craniopharyngioma, chronic renal insufficiency, and other cranial tumor. What do we know about long-acting? This always in the clinical trial. Here you can see that the main common adverse event was the injection site reaction. And it was extremely variable between product. Here you can see 5.3 in the somapacitan, less than 2%, and this is 43% for pain in somatrogon. And here you can see that the other effects that have been reported in the patients were related to patients with antibodies. ADAs were 6.1% in the somapacitan, 6.7% in the lonapixomatropine, and higher than 70% in somatrogon. What is these antibodies in clinical significant? It's not really enough. But what we know that the height velocity was unchanged over time, approximately up to 7 years after this. And what is we know on glucose metabolism? The first line is what we know from the adult, no significant change in terms of HOMA, IR versus daily growth hormone. And what we know from children, that children's GHD, mean glucose and insulin were unchanged versus daily. And so no differences between daily and long-acting in terms of glucose, fasting insulin, or HOMA insulin. So let's go to the last part of my talk, which is the take-home messages. Long-term data showed that daily recombinant growth hormone is efficacious and safe, and that treated children achieve increase in growth velocity and adult height appropriate for target range. The 3 formulation of long-acting for pediatric GHD have showed non-inferiority to daily growth hormone for efficacy in terms of annualized height velocity. And this is in pre-pubertal. We don't have data in puberty. The per milligram calculation for weight-based dosing is different from each long-acting molecule, and also different from that of daily growth hormone. So direct comparison of those of the different molecules are not appropriate. And then safety profile, this long-acting is comparable to that of daily, with no new safety signals identified, limiting to GHD. And IGF-1 sampling is recommended at day 4 and 4.5. If IGF-1 sampling occurs outside, the IGF-1 level can be adjusted using a product-specific correction factors, although taking into consideration the high confidence of interval of confidence. There is needs to capture metabolic impact of long-acting in terms of lipid profile, bone, heart, and others. And long-term surveillance studies are needed to demonstrate adherence, efficacy, metabolic response, cost effectiveness, and safety caused by non-physiological pharmacokinetic and pharmacodynamic profile. This in real-world data following administration of each product. And of course, we need real-world efficacy data are warranted on the AWESOME registry, like GlobeReg, some others in the United States running. And of course, we look forward to have data from the registry in not only for growth hormone, but also for other indication. So that was my last slide. I would like to thank you all for your attention and thank all my staff, my collaborators, staff nurses, and colleagues who collaborated with the study. Happy to take any questions.
Thank you very much, Mohamad, for this amazing talk. I wonder if there's any questions in the chat. I don't see any question at the time. I would ask just 2 brief questions, if I can. The first one was like, it wondered me in one of the first slides that you showed, like about this questionnaire, about how people wanted to prefer in what time of injections. And if you think that multiple injection could be a problem for the patient, would expect that most of them would choose once a month. But instead, it seemed like the once a week was the best chosen. If you could comment on that, because it seemed a little bit counterintuitive in some way.
Yeah, I mean, that was a choice questionnaire, and the answers were related, of course, for the less frequent injection, because this reduced the burden of daily dosing. And but I don't have any comment why people would like to choose similarly weekly to monthly. So I don't have any answer for this. So these were the result of the questionnaire, but and there were no difference between weekly and monthly. So I don't have really this. Although we have experience that people in GnRH analog, for those people who take for precocious puberty, the patients prefer the 3 monthly injections as compared to the monthly injection. But I don't really know why. I mean, this study, the answers were similar.
Questions?
I have a couple of questions. So are there any data on the dosing requirements in transition, also considering potential interaction with agents that frequently are used in this period of life, for example, oral estrogens?
Yeah, I mean, this is a very good question. There are no trial for transition. We know from the pediatric experience that dose after the epiphysis closes is different from the adult. That's between 18 and 25 years. And there are some studies reported in the literature, even by our group. But we don't have data on the transition. I have asked the companies, because you know that the trials, the indications for adult, at least in somapacitan, is between 18s over and over. So I think we need to analyze those data in order to understand what happened for those between 18 and 25 years, and to understand better what is the IGF-1 level, what is the impact on body composition. So your question absolutely is I mean, we need to know much more about this.
Okay.
But I think in the clinical trial, there are data, because this is indicated. As far as the estrogen, I mean, it's something that we look forward, even in the pediatric age, because we know that estrogen will affect the IGF-1 level. And of course, this will happen. And now we have few patients with multiple pituitary hormone deficiency treated with estrogens, and we're looking forward for how to adjust the dosing. I can tell you that with long-acting, all our patients at entering in puberty have very high IGF-1 level. So mean that we need to reduce the long-acting growth hormone dose beyond estrogens at puberty.
Okay. Yeah. So further data are needed, are highly needed to answer this question.
Definitely.
Very interesting.
And in the adult indication in the label, I mean, the dose should be increased. That's in the label for the adults.
Yeah, absolutely. And then another question is, based on your experience, how was the reception of the long-acting in your patients and families? And if you noted some kind of resistance in some groups of patients and families, in what context did you observe that?
Okay, thank you very much, Elena. We have now more than 65, 70 patients treated with long-acting. I mean, we have, since 2008, started a shared decision-making process in the clinic. So we have a research nurse and nurse dedicated to this program, and we don't choose for the patients. That's for daily. And now we have started this process for long-acting. As far as naive patients, they go straight forward for long-acting. Yeah. As far as those who are treated already with daily, some have very good results, and they don't like to switch. So they keep going with daily. So Some where the expectations are not met, and indeed adolescents go to the long-acting. And I can tell you, some who switch from daily to long-acting prefer to come back to daily as well. So this is still an open chapter.
Yeah, it's an open challenge also,
yes,
to characterize
definitely.
Patients who decided to go back and why.
Yes,
So
yes.
in terms of
So
quality of
because
life.
sometimes it's much more painful, like because now we have only one product in Italy, so
okay.
it could be different in the future, and so this is why I think we need a lot of experience in this area as well. And I think for the adult it could be much easier, but I don't have experience in the adults. We have started some experience in transition.
Okay, thank you.
There are two questions or three questions in the chat. The first one is from Imane Belkacem. Hello, should we inject the weekly growth hormone at 8 p.m. like the daily growth hormone?
I mean, the issue, no, because we are not respecting the physiology, of course. The issue is to respect the time of injection, because this will affect the IGF-1 monitoring. Because if you inject 1 day, 1 week in the morning and 1 week in the evening, and you go for IGF-1 sampling, you need to know what is the last time the injection. But of course, I mean, it's also for remembering the injection, because I'm not sure that by giving the injection one week, the adherence is completely there. So we need to understand much more about adherence. So it's better, to my view, to keep the patient at the same time. But of course, there is some flexibility. This is something that adolescents ask. I mean, sometimes if the time could be flexible. The answer, you could be flexible, because you can even miss 3 days of injections and go for the injection. So, and this will not affect your profile in terms of outcomes. So we could be much more flexible.
Thank you. The second question is from Saskia van der Straten. Are there some preliminary data in Prader-Willi syndrome patients?
Oh, I mean, Prader-Willi syndrome, I can understand. First is off-label, with no indications. Second, you need to prove that they have growth hormone deficiency. Third, you need to decide if these patients are good target for long-acting. So, and I think we need much more experience in this area. While we have started experiencing cancer survival with growth hormone deficiency, I'm still reluctant to start with injection for long-acting in Prader-Willi syndromes for many reasons.
Thank you. And the third question, many questions actually. Do you prioritize long-acting growth hormone for patients with reduced adherence, or offer it to all patients with growth hormone disease? So deficiency.
Yeah. I mean, and if you look at the paper we have published in recommendation JCM in January 2025, I mean, this drug should go to some patients with bad adherence, providing you how you measure adherence, and et cetera, et cetera. But as I told you, we have the shared decision-making as well, where we discuss with the family. We make the family aware about the data and the literature, and then we decide with the family. So this is my experience.
Thanks. And then the last question, are there results indicating rise of BMI and changes of body composition to a higher fat mass or lower muscle mass?
This is a very good question. So we have some data on BMI, which is, it seems like the mean BMI is not changing. But I think there is a lot of different changes in different patients, where lean mass is increasing and fat mass is decreasing, even sharply. But this is not in all patients. So we are looking at these data. So we have research protocol DEXA for body composition, for region of analysis, for region of interest analysis, for fat and muscle. And I think we'll have very nice data in the future. We'll look forward. I mean, even for other groups looking at this, there are no data. We have reported an abstract, and there is a paper under submissions for the BMI impact of long acting. So everything we have in there for research for the next 20 years.
Perfect. And I think that it's the last question. I don't know what you say. It's thanks for the wonderful lecture. Do you have experience with growth hormone resistance or GHR problems? And any ongoing trials for this GHR gene mutation and EGF analogs? Thanks.
I mean, of course, long-acting growth hormone is not indicated in this if we're talking about Laron syndrome, because the severe IGF-1 deficiency related to mutation of the growth hormone receptor are not treatable, of course, with long-acting. As far as IGF-1, now that the IGF-1 treatment now will there was, I mean, Ipsen have sold the drug to another companies, but they will keep going with the IGF-1 recombinant IGF-1 production. The only experience we have is on Laron syndrome with severe IGF growth hormone receptor mutation. With good results, not comparable with growth hormone deficiency. I don't know if I have answered the question. It was about growth hormone receptor mutation, which is not.
I think so. I think you answered the question. Yeah.
Okay.
No, thank you so much.